So, this chapter is about anatomy and physiology of pregnancy, specifically the things we as nurses look for and how we can teach our patients related to things like common discomforts and warning signs, and so on and so forth. We'll also talk a little bit about pregnancy tests, what they mean, various different terminology, and understanding what those terminology mean in relation to how we use them. So the first thing is terms that you will need to know these terms and know what they mean. So more than likely, when you look at a chart, you're going to see that a patient is, let's say, a gravida 4 para 2. What the heck does that mean? So when we're talking about gravity, that means number of times of pregnancy, period. No matter the outcome of the pregnancy, no matter how long they carry that pregnancy, if they were pregnant, it counts. So if they are currently pregnant and they have been pregnant 3 times before, that is a gravida 4. So parity, though, is the number of pregnancies that they have carried to reach viability is the technical definition. But if you've already listened to the previous chapter, you know I talked about viability right now in the world is 22 weeks. Well, in this case, when we're talking about parity, what they define as preterm or parity is 20 weeks. So 20 weeks is that magic number you need to know for parity. So this is the number of pregnancies they have carried past 20 weeks. Again, no matter the outcome. If they had a preterm baby that they carried till 24 weeks that was a stillbirth, that still gives them that parity number. So let's say they had 4 pregnancies or a gravida 4, but 2 of those they lost at 12 weeks, then that would put them that gravity 4 parita 2 or para 2. So you see under the gravity and the parity that there is nulla, prima, and multi that you can add to that. So nulla means never. So that is somebody who's a nulla gravida, somebody who's never been pregnant, for instance. Primi means first. So primi gravida, somebody who is pregnant for the first time. Multiple. So somebody who has been pregnant multiple times, for instance. Another way we outline this is the GTPAL system, and it's a 5-digit system that we evaluate their obstetrical history. You will need to know this, and you'll need to know how to evaluate this based on a scenario. So we already talked about gravity is number of pregnancies. Term, if you look over to the right-hand side of your screen, it identifies what term, preterm, and those terms mean. So when we're talking about term, this is anybody who has their baby 37 weeks or more. So once they hit 37 weeks, they have a term baby. Again, no matter the outcome, if they have a stillborn at 39 weeks, that's still a term baby. Preterm is 20 weeks. So once they hit that parity, 20 weeks up to 36 weeks and 6 days. So the day before 37 weeks, if they, again, no matter the outcome, that is going to be preterm. Abortions. Now, oftentimes when people think abortions, they think intentional abortions. In this case, this includes any pregnancy that was lost before 20 weeks. So if they had a miscarriage at 18 weeks, that is considered, that goes under A for abortion. This is any pregnancy lost before 20 weeks. And then L is living children. So this is the number of children they have living that were but were born alive and continue to live. So the first 4 numbers, it's important for you to understand the first 4 numbers, the G, T, P, and A, are all based on number of pregnancies, not number of fetuses. So when we're talking about number of pregnancies, if it is a multi-fetal pregnancy, if they're having twins, they still only get a 1 for that. Same thing with number of term pregnancies, preterm, and abortions. Those 4 are based on number of pregnancies, not number of babies. Living children is the only one that's based on actual number of children, not number of pregnancies. So you could be a Gravida 1 L2 if you had only one pregnancy, but you had twins from that pregnancy. It is possible to do that. So going back over to the right-hand side, going back to that 5-digit system on page 151 in your textbook, there is a chart at the top that shows you several examples on how you evaluate those different ones. So going back to the right-hand side, again, these are terminology that you're going to need to know. Preterm 20 weeks to 36 weeks and 6 days. Full term, once they hit, I'm sorry, I see it says 39 weeks. I just noticed that on the slide. That should say 37 weeks, not 39 weeks. So please make that correction on your notes. 37 weeks is considered term. Don't worry about early term versus full term. Those are really not calculated differently as far as our needs are concerned. And then once you hit 42 weeks, it's considered post-term. Unless somebody doesn't have prenatal care, you rarely see post-term because doctors are not going to let women go that long because of the complications that can evolve from being post-term. Cooking longer is not always a better thing. So let's do a quick example of that 5-digit GTPAL system so you can see how it's evaluated. So in this case, we have a patient who is currently 10 weeks pregnant. Her obstetrical history includes a set of twins that were born at 32 weeks, a girl that was born at 41 weeks, a stillbirth at 34 weeks, and a spontaneous abortion at 13 weeks. How would you label her history? So let's evaluate this. So when we're talking about the Gravida, she's currently pregnant. She has one set of twins, that's 2. She had one baby born at 41 weeks, that's 3. She had one stillbirth at 34 weeks, that's 4. And then she had a spontaneous abortion, it's 5. For the Gravida, it's just number of pregnancies, regardless of the outcome. When we're talking about the term, she only has one term baby, that one that was born at 41 weeks. So, or one term pregnancy. So that is the only, she would only have a T of 1. For preterm, she would have a 2. So in this case, she had a set of twins born at 32 weeks. That's preterm. And then she had a stillbirth born at 34 weeks. Again, the P is just based on number of pregnancies. So even though it was a set of twins, it's still a 1. And even though the 34-weeker was a stillbirth, it still was after 20 weeks. So it's still considered preterm. For the A for abortion, she had one spontaneous abortion at 13 weeks. So she would have a 1 for the A. For the L, she would have a 3. So she had one set of twins at 32 weeks. That's 2. Remember, this one is based on number of babies, not number of pregnancy. And then her 41-weeker is her third one. So here is the outline of that. So we have a G5, a T1, a P2, an A1, and an L3. So hopefully that helps you understand what those numbers mean and how you evaluate those numbers, especially when you see them on the chart. So just a little bit about pregnancy tests. Most people have at least seen or even used a pregnancy test at some time in their life. This is based again on that human chorionic gonadotropin or HCG. That is the hormone that stimulates the placenta to produce testosterone, progesterone, and estrogen. So that maintains those hormones to help maintain that pregnancy. So it can be detected as early as a week or so after conception, which usually is about 3 weeks since the last menstrual period. And the ELISA test, which is also how we do HIV testing, where it's detecting those enzymes specifically, is how it test this. Now, on the next slide, we're going to talk about types, how you categorize symptoms of pregnancy. And this is where pregnancy tests are not a 100% foolproof symptom of pregnancy, is because there are things that can alter it. Things like certain medications, certain tumors, prostatic cancer, for instance. A man shouldn't have a positive pregnancy test, but if they have prostate cancer, they could, because of those hormones that are released related to that. So it is possible to have a inaccurate test result because of some of those factors. So like I mentioned, we'll talk about the signs of pregnancy. They are subdivided into 3 different types. And yes, you need to know what the different types are. So there's presumptive, there's probable, and there is positive. So presumptive is subjective changes. The definition is these are things that are felt by the woman. So in that first column you see down on your left, those are some presumptive signs you may see. Think of these as things that are more vague. Thinking about them, they may indicate pregnancy. So things like fatigue, breast tenderness, lack of a period, changes in skin color, breast enlargement, all those things are possibly related to pregnancy. And these are ones that the woman is going to detect herself. Probable or objective changes, these are ones that are probably pregnancy, but not 100%. These are defined as those changes observed by an examiner. And what I mean by they're probably, but not 100%, an example is that pregnancy test I just mentioned. So when you have a positive pregnancy test, probably that means you're pregnant, but not 100%. There is a chance of error. So these probable signs are a good chance that they are related to pregnancy, but not always. So positive are objective changes that there is absolutely no other thing that can contribute to these symptoms other than having a fetus present. You can't have, if you see a fetus on ultrasound, there's nothing else that can explain that fetus other than the presence of a fetus. So your most common positive ones is going to be visualization on ultrasound. If you hear a fetal heart rate on the Doppler, that is also another important one, as well as verification of fetal movement. So verification of fetal movement could be by ultrasound. When you're visualizing it, you see fetus moving around, or it could be palpation. We'll talk about Leopold signs and all, and how you feel around to figure out baby's positioning, and you can feel their movements and things like that. Even through palpation, if you can verify fetal movement, there's nothing else that can explain that other than the presence of a fetus. So make sure you understand the difference in presumptive, probable, and positive changes or signs related to pregnancy. So a few important things to note with various different body systems. The uterus is obviously the big one that goes through the most changes related to pregnancy. It changes in size, shape, position, everything, especially related to that estrogen that increases that vascularization and that metabolism so that it causes that growth of that uterus. They have changes in contractility because of that progesterone. It decreases that contractility. So that way it's not trying to push that baby out, and various other different things. This can also, as that progesterone decreases, causes those Braxton Hicks, which are, if you ask a pregnant woman, never say they're fake, because they don't feel fake, or they will be described as painless tightening. They can become painful, but the difference in those is they don't produce, they're like a rehearsal. They're like practice contractions. There's usually no rhythm to them. You can't predict them as well as you can true labor contractions, which we'll talk about the difference in true and false labor later on when we do labor and delivery. But though it kind of is practicing for that as it gets later on, that progesterone starts decreasing, allowing for those contractions so the uterus can practice to push that baby out. Cervical changes, things like changes in the cervical mucus, changes in color, that Chadwick sign that causes the bluish discoloration and things like that. As far as breasts, they often have breast enlargement, heaviness, fullness, tenderness, things like that. So when we're talking about cardio is another one that's really important to understand the differences, especially when you have people who have previous cardiac defects, which we will talk about later when we talk about high risk pregnancy. But some of the things that change with the cardiovascular system is their blood volume increases by 50%. That is a huge increase. So the normal adult blood volume is about 4 to 5 liters. So if you're talking about adding another 2 to 2.5 liters on top of that, that's a huge amount of blood flow. No wonder we get so much edema and it's so hard to move around and breathe by the time you're getting to the end. So on page 157, it shows the vital sign changes, the blood volume changes, and the various different cardiac changes, such as cardiac output and all, on page 157. The biggest thing is that increase in blood volume. Um, and also their blood pressure can be an issue. They can develop what we call supine hypotensive syndrome. And this is why pregnant women, especially in the second and third trimester, should never lay flat on their back supine, because it presses on that aortic the aorta, sorry, the descending aorta that runs down the backside, baby will, and it can cut off blood return and blood flow, and cause dizziness. So that's why if a woman is laying on her back and she says, I feel dizzy, you tell them, turn on your side. Ideally, women who are pregnant in the second, third trimester should lay on their side, not on their back, because of this risk of supine hypotensive syndrome, decreasing blood return up to the heart and then blood flow up to the brain. Um, so also when we're talking about coagulation, circulation, there are various lab value changes noted on page 159. I would not take the time to specifically memorize the numbers, because a lot of them don't really change that much, but you should understand why those changes happen. For instance, a lot of times their hemoglobin and hematocrit will go down. Why is that? Well, that's actually a dilutional situation. So I just talked about their blood volume increases by 50%. When you're talking about hematocrit, that's a percentage of the amount of blood cells you have, compared to the volume. So if your fluid increases, then that percentage is going to go down as far as the solid cells. So their hematocrit will go down a little bit, things like that. As far as clotting factors will increase during pregnancy. And I've mentioned before how they have a high risk of blood clots in the postpartum. This is one of those reasons. So your body is very good at adapting. Your body is a well-oiled machine on so many levels that is prepared to set itself up to defend itself. Your body already knows when you are pregnant that you're going to go through a situation that's going to cause bleeding. That is the ultimate outcome, is you are going to give birth to a baby and it's going to cause bleeding. So your body, excuse me, is prepping for that, so that when you do give birth, those clotting factors are going to be increased, so you can cut down on that bleeding a little bit more. The problem with that is the body works so good at increasing those clotting factors that when once baby's born, it takes a couple weeks for those clotting factors to go back to normal, which increases those risks of blood clots. Is just one of those. So when we're talking about respiratory function, you can see in the picture there on the screen how as the uterus grows, the diaphragm and everything in the abdomen gets pushed up, which pushes on the heart, it pushes on the lungs, so it increases their respiratory effort. Not only do they need more oxygen to support all this increased metabolism and this increased blood flow and increased cardiac output, but then they have less room to do it in. So that's why a lot of pregnant women will get respiratory difficulties and things like that, because they are working in a system where they need more, but they have less room to do it in. In addition, I mentioned as far as with the estrogen, how it causes increased vascularization, and because of that, they get a lot more congestion, especially in their nasal area. They can get nosebleeds or epistaxis, so that can impair their respiratory effort as well. So as far as the renal system, they don't concentrate their urine as well as they used to. So urinary frequency greatly increases throughout the entire pregnancy. It's not just in the end when you're talking about the first 2 trimesters. It's related to hormonal changes that changes their filtration rate. So they have a higher filtration rate to filter that fluid through. And because of that, oftentimes their BUN and creatinine will be lower because of that increased filtration rate. And then in that last trimester, that increased urinary frequency is related to having a bowling ball sitting on their uterus, essentially, that is putting that pressure sitting on their bladder, which is putting their pressure on their bladder and causing them to have urinary frequency. I'm going to skip over skin for a second. With musculoskeletal, probably two of the biggest things is your gait changes, like lordosis is very common in pregnancy, where they lean back to support that growing abdomen, and that changes their center of gravity. So they're at risk for falls because of that. Not only that, but they're at risk of falls because of the relaxation of their ligaments and tendons. So there is a hormone in your body called relaxin, um, that your body produces when you're pregnant. The purpose of it is to relax those ligaments in your pelvic area so the pelvis can open up better to allow birth of the baby. But the problem is it relaxes it everywhere. So I don't know how many of you, I had this problem when I was pregnant, that you would just be walking and twist your ankle for no reason. And that is thanks to that hormone that is relaxing all those ligaments to help open up your pelvis, but also again increases risk of falls in that population. So being careful about those risk of falls. As far as lower back pain, because of that change of gravity or change of center of gravity, they are much more likely to have lower back pain as well. Now, going back up to skin, there are several things that are normal alterations that you see in a pregnant woman. That top picture you see of the woman's face, that is called cloasma or melasma. You'll see both terms used, that they're basically used interchangeably, mean the same. You'll hear it called the mask of pregnancy, is where they'll get that change in pigmentation of their skin. A lot of the changes you see related to pregnancy with the skin is related to hyperpigmentation or darkening. The bottom picture is called that linea nigra, which is where they'll get that dark line, that dark vertical line along their abdomen. Very common as well. The striae gravidarum is your stretch marks. Not everybody gets them, but they do tend to be genetic. Angiomas is like your spider veins, not considered concerning. Palmar erythema, they'll get redness of the palms of their hands and the soles of their feet. And pruritus, it's very common to have just itching related to pregnancy, especially across the abdomen. Now, when we're talking about the gastrointestinal system, there's several things. Nausea and vomiting is probably the most well-known complicated, I don't want to say complication, side effect of pregnancy, related to hormone changes, especially that HCG or human chorionic gonadotropin. In fact, instances where it causes a very high HCG level, like we'll talk about when we talk about high risk pregnancies, hyperemesis gravidarum, where they have a really hyper sensationalized nausea and vomiting to the point they need hospitalization. That has been associated with really high HCG levels. So certain hormones can cause that increased nausea. Heartburn, constipation, those are related to not only the growing fetus pressing on those, but also constipation can be related to decreased peristalsis. So I already mentioned how progesterone calms down contractions. It is the calming voice of your uterus so that your uterus does not contract and push out this fetus. But it doesn't just localize itself in the uterus, it also works on your intestines. So not only is it calming down your uterus, it's calming down peristalsis in your gut. So that's why constipation is a very common concern with all pregnant women as well. With the mouth, you can get bleeding and gum swelling really easy. And again, that goes back to that estrogen increased vascularization. So it's important to promote really good oral care to these patients, not only for comfort and, of course, for hygiene reasons, but also poor oral care can increase risk of preterm labor. So that in of itself is a reason to increase their oral care. Um, One thing specifically, well, not specifically to pregnant women, but is something you see in pregnant women more so than you see in the general population, is called pica. So pica is something you see with pregnant women, and you see it in some psychiatric and developmental disorders as well. So pica is defined as when you have non-food cravings. So this is when people consume things that are not generally things you would eat. Even ice is considered part of pica. That is a common thing that pregnant women like to eat. I'll be honest, I like to eat ice too. So but it is could be ice, it could be clay, it could be dirt, it could be things like baking soda, cornstarch, things you wouldn't typically eat by themselves. Oftentimes, pica in a pregnant woman is related to iron deficiency, and that's how it comes out. Instead of them craving, say, meat or beans or whatever it be that would give them the iron to produce those additional hemoglobin cells, they start craving those non-food items. So recognizing that and helping to educate the mom on that, and making sure they're taking those prenatal vitamins with iron can help with this. So when we're talking about adaptations to pregnancy, it's important to recognize those adaptations and give preemptive teaching to our patients so they can not only recognize those and differentiate normal adaptations to concerning things, but also teaching them how to manage those.